HSE Live following this, please use headsets if you have them. The sound is much better. As you can probably hear, the sound here is a little iffy because we've got quite a high ceiling. But look, we'll get into the briefings and then we'll get on to the Q&A. So, Anne, if I can ask you.
Thanks, Paul. Hi, everyone. I'm just going to talk through some of the numbers, really, in terms of what we are, I suppose, working with in terms of long-term residential care, and then we can take questions afterwards. So just in terms of, making sure that moves first, just in terms of the numbers there, we can see that in terms of long-term residential care, we have 335 outbreaks. Now, it's important to say that an outbreak isn't the same as a cluster. An outbreak is where there is a confirmed case. So that may be one case, and it could be a case for somebody who's a resident in the unit or a staff member in the unit. So currently, today's figure, we're dealing with 335. You'll see there on the right there, in terms of the breakdown by area, we have, from I suppose our perspective, we look at the overall number of facilities and the support that we are giving. So we have a range of supports, and I touched on this previously, in terms of the different types of supports that we give to long-term residential care. And maybe if I just put this into a context for you, in terms of nursing homes in Ireland, you will be aware that we have over 550. In Ireland, the public provision of long-term residential care for older people is only about 20% of what is provided by the private sector. So for us, since the beginning of COVID-19, we have been, I suppose, putting our arms around the private nursing homes more in a way that we would not previously have done. So we would never have had a formal relationship with private nursing homes prior to this. Their relationship would have been with HICWA, and we would support them in relation to some health service provision, but not in the way that we are now doing. So for us, this has been a very significant exercise in terms of increasing the support to that number of facilities all around the country, as well as increasing the support in our own public facilities for long-term residential care. So we have supports available across telephone advice, we have infection prevention and control support, we have public health support, and public health has been a critical part of our response to outbreaks across the whole sector, and particularly in long-term residential care. And this would be an area where historically we would have supported residential care settings. So in terms of our flu season, or in relation to norovirus or any other outbreaks that those homes may experience, we would always have provided public health support in terms of the management of those outbreaks. But clearly what we're talking about today is at a different scale altogether. And we've also been providing PPE support. So you'll see the breakdown there in terms of HSE only facilities and then the non-HSE facilities. We are now clear that there is no difference in terms of the public-private picture around long-term residential care. And just to say, in terms of the types of facilities that we have when we talk about long-term residential care, predominantly it relates to older people, people with mental health difficulties, people in disability settings, and then there's a few others that we count that, for example, could relate to addiction services. But just in terms of the settings that we have, so just to move on there, we have, as I said, 335 long-term residential centres experiencing an outbreak at the minute, and 196 of those outbreaks are in nursing homes. We have 49 additional centres that would be community nursing units, which would be more of a HSE provided service where older people are also resident. But importantly, those centres can do other things as well and have different types of beds, so it becomes a bit more mixed when we look at those types of facilities. But in terms of nursing homes, it's 196, and as I said, that relates to residents or staff, not just residents. In terms of the actual outbreaks, you'll see that there was a significant increase there earlier in April, where I suppose the numbers grew. In the last week, they've stayed relatively high in nursing homes. There hasn't been a massive increase in terms of the number of outbreaks. Now, it's important to say that there can be people who will test positive for COVID that we may not know about. So in terms of the confirmed cases that we have, this would reflect those. But there may be others, so it's not, we can't say definitively that there are no other cases. You'll see then on the next slide, when we look at the different areas of the country, there's a predominance there in the east of the country, CHO9, CHO7, etc. So in the west as well, Galway have experienced a number, but our challenge across everything to do with COVID-19 has related predominantly to the east, whether it is in relation to our acute hospital system or our long-term residential care system. And just to highlight that, you'll see there the numbers by county. If you look at Dublin, are way, way higher than anywhere else. So Dublin is definitely our key focus area for this. So what are we doing? We have been working closely with nursing homes. That contact started at the end of January and really throughout February and March, and we touched on this on Sunday. There have been a range of different types of communications and work underway. For us as well, I suppose it's important to note that the support to our long-term residential care settings would come from our community services, and across the board, but also in our community services, we are also challenged in terms of responding to multiple other demands. So, for example, the establishment of our community testing sites, the establishment of clinical hubs, the support now for all of the long-term residential care in the context where we are also experiencing some COVID-related absenteeism across the board, with quite a significant number in some areas. So in terms of the actions that we've taken, we decided at the beginning of this, in terms of the work that was underway, both from a NEFIT and Department of Health perspective around vulnerable groups, but also within the HSE, where we established a very dedicated work stream looking at vulnerable groups. We included long-term residential care in that. We've been working closely with the Department of Health in terms of the supports available to long-term residential care settings and to nursing homes, in terms of the challenges that they are experiencing. And clearly, the nursing home sector is experiencing the same challenges that we are experiencing across the board in terms of, for example, the supply of PPE, the availability of staff, absenteeism, etc. It's a common picture, and we're just trying to address it across the whole lot. We've been engaging closely with Nursing Home Ireland and working with them throughout February and March and still in April in terms of supporting the nursing home sector. So whilst we are working individually with nursing homes that are experiencing difficulty, we are also working with NHI as the umbrella body. We've been providing direct PPE, and again, that's something that has received a significant amount of coverage. Historically, we wouldn't have provided PPE. So nursing homes would have had their own PPE. Again, these are entities, private entities. They would have their own PPE, their own staffing, etc. However, we have noticed, particularly since the end of March, an increase in requests. So prior to the end of March, we were not receiving requests of any significant number for PPE in private nursing homes. They were in the main working off their own supplies. Since the end of March, and I think our first real deliveries to private nursing homes came around the 17th of March. So we've seen that grow, and particularly since, I guess, the first week in April. And again, this was referenced on Sunday. So in the last 2 weeks, we have seen a very significant growth in the number of requests for PPE from private nursing homes. And again, we are also continuing to provide the same support to the CNUs and the HSE units that we have responsibility for. We also have been looking at the provision of staff and redeployment of staff. Again, the requirement in nursing homes differs. So some nursing homes actually need staff, others need access to expert advice and support. So we've been providing that as well. Colm, as Chief Clinical Officer, has convened the AMRIC group, which is an antimicrobial resistance and infection control group, and that has representation from across our services. And we have been working on a training model in terms of webinars, etc., with the nursing homes. So what are we doing next? We're going to continue to deploy staff to teams locally. We're going to implement a CRM tracker across private nursing homes to capture their data, and we can report that into NEFIT. And we're going to enhance the testing that's available in the private nursing home sector in terms of testing people on site, residents and staff, and continue to provide PPE and oxygen to sites as required. So I'm going to leave that there and happy to take any questions. Thank you.
Just briefly, a few points on the clinical care. As Anne said, the long-term residential care facilities, a huge range of services and facilities, over 2,000 facilities in total, including HSE, voluntary, private, other entities such as addiction. And when you look at the nursing home sector in particular, there's over 550. The great majority of these are private, many of them are small. And the nursing home is what it says in the box. It's a home for these residents, many of whom are known to the staff and the nurses and the doctors who provide care there for many years, and for whom they're as much part of an extended family. And I saw that myself when Anne and I visited St Fintan's in Portlaoise yesterday, where the impact of each death, which is a tragedy, of course, to the family and friends of each person, but was also had a huge impact on the staff who had come to know the patients for many years. So the care provided in all these settings, there's a range. For the private nursing homes, it may be a single GP or GP practice or a range of GPs working with the nurses who provide care. And these GPs over the years will have developed skills and interests in the care of older people, in end-of-life care and the management of chronic disease. In some of the community hospitals, which are HSE run, and I'm familiar myself through my own department in Cork City, the care will be provided through an extended outreach programme from the geriatrician community to places like Macroom Hospital, Mill Street Hospital, that I know myself from visits during my time as a clinician in Cork. And the challenge, of course, with these settings is that in terms of impact, is that we know, and you'll all have heard those figures, how 80% of people who catch the virus is a mild or self-limiting illness. But among older, frailer people, it's particularly virulent in the sense that it can cause serious illness and, of course, even death. The other factor to consider is that with older people, presentations are unusually, they're atypical. For any of us who imagine ourselves, for example, to get pneumonia, you'd expect to get cough or shortness of breath or fever or feel very unwell. With older, frailer people, some of those cardinal signs, which actually are signs of your immune system responding, are not there because their immune system is weakened in time due to age or frailty or other comorbidity. And those key features of serious illness, such as a high fever or such as a rapid respiratory rate or distress, may not be present. And as such, the illness is much more difficult to detect. And if you can imagine, for example, in one particular case, somebody who may be bedbound, have advanced dementia, detecting a change in their condition from what is their baseline status is particularly challenging. So the outbreaks, as I said, I refer to the experience we had yesterday as what the kind of coordination we like to see is that cohesive work between public health departments, who are the experts in outbreak management, in case identification, in testing, in cohorting patients, in isolation, tracing and advising staff, and indeed playing in and feeding into the clinical advice. But hand in hand we saw in St Fintan's yesterday, led by the local clinicians, John Connaughton, Sean Fleming, working with Maurice Girvan, the clinical director of psychiatry there, and Tracy Quigley, the ADON in St Fintan's, this coordinated approach where each patient was managed as, I say, people who were very familiar to the nurses at St Fintan's Hospital, like extended members of their family, where the care was provided on site. Some of those patients were known to the acute hospital from previous admissions, but through senior clinical advice and opinion, including end-of-life care, each decision was made on each individual's best interests, and that was to provide the care on site, in their home, in their familiar settings, by the nurses who knew them best. And these supports, when you look at the whole range of nursing home facilities, it's public health response in terms of limiting the transmission of the virus and containing it, and it's the existing clinical governance, be it through general practitioners, be it through the existing nursing staff with enhanced supports, particularly in the areas where enhanced support is required, be the specialist advice in hospital, or be it indeed consultant geriatricians, giving examples from Galway and other places of consultants providing outreach advice to nursing homes, or be it end-of-life care. So finally, as I said, as it is, each death is a tragedy, and our aim, and this is an incurable illness. It doesn't matter where you are in a nursing home, at home, in hospital, intensive care unit, or transferred to the highest spec ITU unit in the Western world, that there is no treatment for this disease. And as such, each judgment must be made to clinicians based on what they think is appropriate for an individual, and based on maximising their comfort, and if it appears that they're entering end of life, to make sure that they can live out those last few days in dignity in the setting with people with whom they're familiar. So thank you, and I'll take any questions after.
Okay, so we have a microphone roving on this, so happy to take the questions that you have. Clearly, we know you. People at home may not, so I'll ask you to introduce yourself and your media organisation. So, Cor the Law Visos. Yeah, Evelyn, we'll start with you there. You're hiding behind.
Hello. My name is Evelyn Ring. I'm a reporter with the Irish Examiner. The Irish Hospice Association have called for loved ones to be by the side of their relatives when they're at the end of life, and they said they have put those recommendations to you. Where stands those recommendations?
Colin.
I understand that, and we saw examples again from yesterday of how for the widow of one person who died, how she was able to link by video link, but it still was clearly very hurtful and that she was, or painful for her that she was unable to spend direct contact with her husband as he died. The current advice we get through this is through NEFIT, who give advice on contacts, and any such advice or requests from the Irish Hospital Association, we will look at through the expert advisory group, which advise on any restrictions or ease of restrictions through NEFIT, so there's a common policy and a common understanding throughout all healthcare settings. So I understand and appreciate the need for people to be beside their loved ones if they're dying, and clearly we have to balance that with the compelling public health interests we all have had to observe in very difficult circumstances, although less difficult, in keeping social distancing and avoiding transmission of the virus.
Okay, Evelyn. Okay, Richard.
Hi, Richard Chambers from Virgin Media News. Just in terms of specifics, Anne, you mentioned deployment of staff to nursing homes from the HSE. How many staff are going to be deployed? We heard Simon Harris talking about COVID response teams. How many different nurses and doctors will be deployed as part of these units, and where exactly will they be deployed to?
Okay, so we're looking at that in all areas around the country. We have officially redeployed 61 people, but I think it's important to look wider than that. So we have on occasion, for example, deployed the National Ambulance Service. We send staff out just to bridge a shift. So they're not redeployed to work there forever. They literally get the nursing home over whatever that particular crisis point is. We are looking at that in more detail in terms of working now with Section 39 providers and working with our home support agencies to see can we redeploy people from that sector, people who are used to working in caring environments and in residential care in particular. In terms of the response teams, we will have those in all areas. And what we are working on now is having a lead person in each acute hospital who will be supported by a team of experts. Because in many cases in the nursing home, it's not about putting staff into the unit. It's very important that the nursing homes can be enabled to continue their work. But they may need access to specialist guidance, for example, around, it could be to do with prescribing, it could be to do with infection control or whatever. So for us, the priority is to ensure that we have that specialist expertise available to nursing homes so that they can continue to function and, where necessary, provide additional staffing supports. But that changes on a daily basis. We're not going to have, a picture every day because it's done at a local level and people respond immediately then to the call. We have more work to do on it, so we need to redeploy more people as necessary, and we are working on that. But as you can imagine, in terms of the pace of this and the scale of it, it's something that is a huge challenge for us. There's no doubt about it.
Siobhan, just come in there.
So just to comment on that, the expert guidance may not necessarily be available in person, but it's available over the phone. So we're also working on other strategies to provide the guidance. So that may be through telehealth, and we're working on that as well.
Okay, Richard, again.
So you couldn't sort of say that, as has been suggested by some infectious disease specialists, that doctors and nurses from hospitals or from GP clinics might be deployed to specifically look at nursing homes. Is that something which is going to be happening?
I think it's more nuanced than that. So I think the solution is different in different areas, and certainly from a nursing home perspective, they have different needs. It's important to say that, and it was interesting to hear Mary Dunya from HICWA talking about this during the week. It's 30% of nursing homes that are experiencing cases at the minute. There are 70% that aren't. So it's not a single common picture everywhere. And some of the nursing homes that are experiencing cases aren't actually experiencing many difficulties in managing that. So it's very different as we go. And I think that in terms of redeploying doctors, we have to be careful. So in terms of GP staff, we need our GPs to be able to continue to do what they do. We are also setting up clinical assessment hubs that will involve GPs. In terms of hospital settings, we are absolutely looking at using supports as necessary. So depending, but as it stands at the minute, the need for doctors to be redeployed, we're not there. And in reality, nursing homes don't employ doctors. They are supported by GPs. So it is about having sufficient support available to respond to nursing homes in a local area.
Could I just add, one of the things to remember about nursing home settings is not I know none of us would not to confuse them with the type of care in acute hospitals. One of the things that nursing homes are very good at is continuity of care. Residents on average across Ireland spend 2.5 years in a nursing home. In many cases it's much longer, and the place we visited yesterday, there were some residents there for more than 10 years. And that continuity of care is more valuable than any information or tests an acute hospital can do in the emergency department, because it gives context to the patient, it highlights their needs, their individual foibles, the way they react to illness. And so I would certainly feel my own role as a geriatrician that the people best enabled to give care are those who are most familiar with the patients, and our strategy should be in supporting them to give the right care rather than replacing it.
Okay, and just we're going to slow it down, for Vanessa's just said we're moving too quickly between one frame and the next, so we've got to allow 1 second at least of a breath to allow them to get into the picture. Okay, Alva, introduce yourself there, please.
Alva Keneally from RT News. Just wondering how isolation will work in nursing homes. We're hearing of some nursing homes that are under pressure, that they feel they don't have the facilities to isolate, and have requested whether they can isolate people who are positive COVID-19 residents elsewhere. What's your direction there?
Well, each institution is different. Many of the private nursing homes are new and will have isolation facilities or single-room facilities. The problem really pertains to older facilities that are multi-room occupancy. The public health advice is more nuanced than it's not exactly binary. If you look into the kind of advice they give to anywhere, whether it's a hospital or a nursing home, it pertains to the stage of somebody's illness, if they're negative or unknown, don't have COVID, and never been in contact with somebody, then it's cohorting them away from anybody who could have been in contact. So there's different stages or different degrees of risk. Clearly, with the newer places that have, and most private nursing homes would fit this description, they have single room facilities which lend themselves very well to isolation. With older facilities, it can be a problem. We find that in the outbreaks, and referred to that, what we've done is, as happens in St Fintan's, is we cohort patients together who are positive, trying to do so at the same stage of illness, because some people who are very sick shed large amounts of virus, while others who are either early or recovering may not do so. So cohorting, the preferred route, certainly single room, where there's groups of patients, as in hospitals, is to cohort them in single wards or single areas, and that minimises the risk to other people. It also is more economical for the healthcare workers, who can then treat COVID-only areas, and it also helps us preserve our stock of PPE, as the same stock can be used from patient to patient. So there's a different situation in each site.
Siobhan, do you want to come in?
Just to add to that our public health doctors are guiding us very much on how to do that in each facility, and they take into account what the facility has available to do it.
Okay, Alva, have you any follow-on there? Okay, just one other follow-on.
Well, the question is
come on.
third
Dr. Henry.
Can I ask, the alternative accommodation that you've offered to healthcare staff, is that being offered to nursing home staff as well?
Yes, it's offered to anybody working across the health sector, so whether you're in a HSE service, a private nursing home, direct provision, anywhere.
Do you want to give an update on what we've done to that, because it is an important one?
We issued that guidance, so that went out last week, and there are link people in each area now that can be contacted in terms of accommodation, so it's obviously very important for us. We're now looking to see what the uptake has been, because some providers have had their own arrangements with hotels nearby, etc. So clearly that is very important for us in terms of supporting staff. The other thing that's been important has been the occupational health support, so working with nursing homes in terms of the occupational health guidance around essential workers. So we have been supporting them in that regard too.
Okay, Kesh Berlin or Gelga?
The only confirmation we've had regarding the number of people who've died is coming from HSE-run homes. Will we get more transparency from private nursing homes over the coming weeks? And finally, Kesh Oscuelga Lahai column Cade and Scale Fuina Tihi Alston.
Asperla.
So which question? The second?
Asperla.
Sorry, which question do you want me to answer first, in English or Irish?
Asperla Arish.
Oh, sorry.
Yeah.
So deaths was the first you want to answer?
Just in relation to the fact that the confirmations have come from the nursing homes you run in terms of deaths, and would there be more transparency now that your staff is moving into private nursing
If you look at the total number of deaths as reported, it's 486 to date, and I just have to think, 263 we know are in nursing homes and 298 in hospitals. And that shows you that there is transfer, because the figures don't add. It shows you there's a transfer of some nursing home patients to hospital settings, but they're categorised as having come from nursing home settings. So we have figures on the way it's reported is where the origin of the patient, whether they came from nursing home settings, and we do know that about 60% of deaths of people came from long-term residential care settings or thereabouts, and some of those people were transferred to acute hospitals for further care. Well, it's cúis brónach dín goil a méid sin dín go frisid bás do an vír sé man bhfuil sa ahan daine tan a vírus an galar héna sin vírus se si do leista agus búilte go toban agus níos mó na insceafta eile daine éist agus iad bhfuil lag agus iad bhfuil fechóram na tí alsnis cena féin. So is tamid díirún is na choras tastála agus an choras chóram atáganne. If you want ní bhaint na tí alsnis agus ach na daine agus na chórlóirí tas na ospidal géir chórmacha tamid íri a níorú hig na tí alsnis sa dóis go mé siad abad a teacht ar na sciilne is fearr agus an cóla is fearr chun an sais cólais is fearr a chur fahráid na thuirlig.
Okay, Shane.
Hi, Shane Beattie from News Talk. And can I ask you about one of the next steps you're doing is enhanced testing, which people may hear about. What exactly does that mean? Does that mean it's residents who don't have symptoms in nursing homes where clusters or outbreaks haven't been identified? What exactly does that mean?
So we're looking at testing, so in a nursing home where there are confirmed cases, that we would proceed to test everybody. And that is something that is a clear requirement in terms of our capacity to track this and provide really the most accurate data in terms of informing this epidemic. So we are looking, up to now, we have had the National Ambulance Service deployed to do mobile testing in nursing homes on the basis of a suspicious case, and that is continuing, but we are now scaling up to be able to test all residents and staff in nursing homes where there are confirmed outbreaks. And certainly we're being guided by that by public health colleagues, but initially that will be scaled up with our National Ambulance Service because they're mobile, but also then in terms of redeploying staff who have been doing swabbing, or ideally within nursing homes themselves. So we know that in nursing homes, many homes already do swabbing, for example, in the flu season. So we're going to be working with homes in relation to them doing more of their own swabbing. Now that our laboratory capacity has increased, we are able now to do more testing and to have those results turned around more efficiently than previously. So that is absolutely what we're doing now.
Just one other question. For people who feel that these announcements are in some way an admission that maybe you got it wrong or that you're now playing catch-up with nursing homes, is this an admission? Do you recognise that in the early days you got this wrong in nursing homes?
I think this, I suppose, in terms of how this has gone, you know, as I said earlier, we have a number of units in the HSE that are older person services. However, it is only since the end of January that we have started working with private nursing homes. Colin can talk more about the public health aspect of it, but we have been working with the nursing homes, and I think we have at all times been guided by public health advice and by NEFIT and all of that, and that I think has been well aired. But for us it is clear that there is an absolute requirement for us to do more, and this is a very, very big sector. And as I said, prior to this, we did not have a formal relationship with all of these effectively private homes, and we are doing what we can. It is very difficult, just the scale of it, the pace of it, and we know that certainly in terms of the impact of older people. But I guess, you know, for us, it is about actually doing everything we can in line with what we are providing for the public HSE units. So there is now no difference, but it is a very significant task, and we're working very closely with HICWA on this, and we have a very joined-up approach with them and their expertise and knowledge of the sector, which would be far greater than ours, and also working with the Department of Health, for example, in relation to the supports available to nursing homes. So we're doing everything, but it is a very fast-moving across the board, not just in terms of nursing homes. So the pace of this, the scale of it, and I don't know, Colin, do you want to say anything about the public health element?
Just second.
Just to say, from the clinical point of view, we've been developing the clinical responses for long-term residential facilities from very early on this year. That's been led by our National Clinical Lead for Older Persons, Dr. Siobhan Kennelly. So that started in very early February, and that was the first when we started to develop our clinical guidance. That was the first area, that and ITU were the first areas we focused on. So we recognised the potential difficulties in these facilities, particularly for people like Colin and myself, who've worked in them and who work with older people. So we recognised that early on and started to develop clinical guidance very early for those areas.
Okay, John.
Hi, John Mooney from the Sunday Times. Could I ask two questions? First of all is, in terms of the distribution of personal protection equipment to nursing homes, these private operations, is there any criteria put down on that in terms of it being supplied to them? The second question I'd like to ask is, when a death occurs within a nursing home from COVID, do you feel or do you have any sense that people have died within that system and possibly their test results haven't been completed yet or analysed yet, and therefore the numbers that are dying within them are possibly being understated at the moment?
I'm going to take the
PPE.
first one and then I'll hand over the second one.
Yeah.
So in terms of the PPE, there's no restrictions. I mean, I suppose across our whole system, we have been challenged, and you will all know this in terms of PPE, but we are not treating private nursing homes any differently. We do about 250 deliveries a day to community settings and private nursing homes. We have, as I said earlier, it is only really since the end of March that we've experienced, I suppose, a significant number of requests from private nursing homes for PPE. But if you take last weekend as an example, we had, I think on Monday, it was 165 planned deliveries of PPE and a further 375 that had been unplanned. So we are responding. We have a mechanism now for responding to any site, including a private nursing home. So there is no differentiation, and we are supplying what we can as required. I don't know, do you want to add to that?
Question, can you hear me all right? Can you hear me? Yeah, the second question is an interesting one for us and indeed for Neferton, is whether or not cases are being missed among older people who are dying. And as I mentioned earlier, you might have heard that the presentation is not always clear in older people, and as it's part of the life of nursing homes and community care and community hospitals that there will be people who die there. The average length of stay in somebody in such a setting is 2.5 years. So what our public health people are doing is tracking any increased, trying to discern if there's any increase in unexpected mortality in nursing homes. In other words, are there people dying that we wouldn't know about because they weren't detected during life, because the symptoms weren't there, because they were already weak, because they had some other illness. They may have been dying of cancer, or may have been end-stage dementia, and was COVID on board, and as such did it accelerate death or contribute to death. And so they're tracking this at the moment. There is some, and you'll have seen that announcement yesterday where I think the CMO wrote to the coroners who went communicate with the coroners or to the undertakers to accelerate the recording of registration of death so that we reduce any lag time in registration through to our surveillance, which is normally a couple of months old, in tracking such trends so that we can bring that forward and look at real-time trends. I'm told at the moment, based on somewhat historical data, that there's no trend noticed, but we're watching. I couldn't confidently say yet that that's completely up to date, and once it is up to date, we'll certainly let you know.
Okay, you finished, Anya? Done? Okay, Grania.
Hi, Grania from the journal.ie. I might talk about, or I'd like to ask about what was said about what is being done to stop an outbreak turning into a cluster in nursing homes. What would you say to families who are concerned for their loved ones who are in residential care settings about what is being done to protect their loved ones? And also on a different subject, a couple of GPs have been in touch to say they've been asked to notify the Department of Public Health if there are confirmed cases. A bit of confusion there. In what circumstances would GPs know when there is a confirmed case and the Department of Public Health wouldn't?
The first question, just to assure people that in terms of preparedness for nursing homes and in response to a case or suspected case, it's one of the questions. There's been absolutely appropriate scrutiny in nursing homes and nursing home care as a result of the COVID virus, but it's important for us all to remember that they're experts in providing continuing care, and included in that is infection prevention and control. So many of the skills are already there. The difference now, of course, is the public health departments distributed around the country are actively involved in nursing homes where there are suspect or proven cases. And where I was yesterday, to give you an example, Abby Collins, who's the Director of Public Health locally, has been in contact with private nursing homes where there's a suspect or reported outbreak. She's provided them with pack and advice on isolation, on testing, on cohorting, on infection prevention control, and linked them to appropriate service in hospital. And that's the kind of practice we like to see throughout the country. And the second question you had was?
GPs been in touch about notifying when there are confirmed cases of COVID-19. But I suppose that we're expecting that to come from.
Yes, the testing is the GPs have facilitated us all greatly by being the people who, if you like, triage the testing and through the health link onto the swabbing centres and onto the labs. But the testing, there's to be any doubt, is an enabler of public health actions. So the people who then are responsible for receipt, communication, acting upon those results are directors of public health through their respective departments, because the purpose of the test is to trigger those critical public health activities which break the chain of transmission of the virus and try to contain spread. But clearly GPs as the primary caregivers are involved in the results that come through to patients.
Okay, happy, Grania? Okay, Paul.
Paul Cullen, the Irish Times. I'm trying to understand how things have got so bad in the residential care sector. Cases have surged, maybe not in the last week, but in the 2 weeks before that. So if you go back to Paddy's Day, the day of the Taoiseach speech, so we know, at that point, we knew for months that coronavirus hits older people disproportionately. We knew for weeks that there were problems in nursing homes in Seattle in America. Nursing Homes Ireland say they've been knocking on the door trying to get a hearing from department. Have you any theories why, at that point, given the incubation period of the diseases, up to 14 days, why the cases have taken off so badly since then, when we were armed with all this knowledge, and as Siobhan says, preparations for the clinical response were ongoing since the start of February? How on earth was the door left open to the disease so much?
Okay, Colin.
I may answer part of that, Paul. It's a hard fact that this is a highly contagious virus, first of all, and secondly, it has a severe impact on older people in any congregated setting. So the virus was likely, for example, in school or younger people's settings, was likely there but had little or no impact. So that, coupled with what I mentioned before with its atypical presentation and with healthcare workers moving between patients, meant that transmission probably was occurring at a certain level at that time, long before it became evident. Yes, it's a huge challenge for us in any residential care setting because of the congregation of older, frailer people in any one building, and limiting transmission in those circumstances is a huge challenge. I can't deny that. As to your question, should things have been done earlier, time will tell whether action should have been taken earlier. We know from other European countries our own reporting of mortality, which, as you know, isn't reported elsewhere, shows unfortunately the same story is replicated right across Europe. That's no excuse. I'm just saying it highlights the vulnerability of residential care settings for a virus which is highly transmissible and highly communicable.
Siobhan.
Just to comment further on that, the facilities, the congregated facilities or long-term residential facilities are all very different, as we've alluded to earlier. The more modern ones have rooms that people are in on their own, older ones have bigger or more Nightingale wards, which Colm again alluded to, having visited in St Fintan's yesterday. So it's very difficult to make people sit down and stay away from each other and maintain social distancing. And staff have worked very hard to do that, but sometimes the alternative of leaving people completely on their own or giving them an awful lot of medication to sedate them is not necessarily a good alternative either. So it's trying to balance all those risks and keeping patients as safe as possible in the environment that they're in.
Paul, have you another question? Or
I'll ask one more.
We can come back to you if you want.
Yeah, just so about 1/3 of homes have cases. So can you tell me what can you say to reassure families of residents in the other 2/3 of homes? If you can give me 4 things that are being done now to ensure that those homes don't suffer the same fate as the other ones.
4 things.
Well, maybe I'll start off with one, maybe I'll share them with Siobhan and Anne. There's a heightened sense of awareness now, Paul, of this disease. So if somebody, rather than look for fever or cough, now if somebody goes off who's otherwise, for example, bedbound, unable to speak, there's a heightened sense of awareness and perhaps a lowered threshold for thinking about COVID-19 as a possible diagnosis. Secondly, our consultant geriatrician community and our hospital community, there are some good examples of them providing direct on-site advice or video advice. We saw an outbreak at St Vincent Parish Hospital, where I work in Cork, where it was managed by consultant geriatricians from the CUH and Mercy Hospital, and some patients were transferred. So there's now an active outreach. We see Sean Kennelly, geriatrician in Tala, providing video advice to nursing homes. So there's much greater and much richer and much deeper enhanced advice and links between hospital partners, where there are already links, and the residential care setting as a result of outbreaks. And that's born out of, I believe, the altruism of medical and nursing profession, that we see it as a challenge for all of us and not for any one section of the healthcare profession. So there is a much stronger sense of link now than there was even a couple of months ago.
I think I might come in and say another thing that we're doing, Paul, is to ensure that we support the nursing homes to have staff by increasing our testing. So currently, if a staff member is out, they're in isolation for 14 days, they may or may not have COVID. So a priority for us is to work with the nursing homes to enable them to get their staff back, because clearly they need staff to be able to care for patients. So that's something I think that we're all very, across all services, not just in nursing homes, but the priority for staff to be able to return to work as quickly as possible to care is a key priority for us.
You settle on 3, Paul? Okay. Evelyn?
Anne talked about scaling up the testing in residential care settings where there was an outbreak, that everybody will be tested. Did I understand that right?
Where there's a confirmed case.
When will that happen?
We're working on it now, so we made a decision yesterday, and our public health colleagues are working up the, I suppose, more detailed guidance, but we are starting with facilities where we have particular concerns around outbreaks, and our National Ambulance Service is going to start that while we look at other staff being redeployed to testing, or critically, as I said, working with nursing homes in relation to doing their own swabbing. And we already know of a number of homes that are doing their own swabbing and are receiving very timely tests. So there's already a relationship in a number of parts of the country between private nursing homes and their local hospital. Again, this is something that's relatively newly established, where they are able to bring tests and receive results quite quickly. So we are going to build on that as of now.
Richard?
I've been speaking to some family members of residents in St Mary's in the Phoenix Park, and they say that the first they heard of any COVID outbreak in St Mary's was in the news headlines this morning, when they heard that 11 people had lost their lives. Is that an appropriate way of treating families who are rightly concerned about their loved ones in the midst of this outbreak? Is there any protocol there for informing family members of residents in nursing homes or in residential facilities run by the HSE if there is a COVID outbreak?
Well, I didn't hear what you're referring to, but I think in terms of communication, clearly we would want there to be communication between, and invariably there is. So it's very important that people are communicated with. I think a particular challenge at the minute clearly is that we're not having as much family contact and visiting, and all of that informal exchange that we would have in normal circumstances between staff and family members. That's just not really happening now because we're not having as many visitors. I think that, clearly there's, people who have relatives who are testing positive. They are involved in their care. So I'm assuming that the reference there is to people who aren't family members of people who've tested positive. So there's also, I guess, a confidentiality piece there. I think in terms of the overall ethos of a unit and how they are responding to this crisis, that there should be communication around that.
Just a point that Stephen Donnelly raised, he said that PPE equipment ordered by private nursing homes had been effectively intercepted by the HSE, that when the nursing homes had rang up the suppliers, they were told the HSE had taken over the orders. Is there any comment on that?
I don't know about that. What I do know is that we have been sourcing PPE at a national level for all providers. I'm not aware that we've been intercepting anybody else's orders, but this, as we know from other events such as this one, the securing PPE availability globally is a massive challenge. We are now providing private nursing homes with PPE. So I don't actually know what you're referring to. I'm not aware of any of that. But I do know that we are including them in all of our ordering, deliveries, etc. And critically the clinical guidance in respect of how PPE is used in units.
It's important to note as well, Richard, that the vast majority of RPP is coming in from a single supplier from China. We have other suppliers as well, but the vast majority is coming in from that single source. So it's hard to see how that could have happened. Not saying it didn't, but hard to see how it could. Alva?
Just wondering, could you confirm a story that was on prime time last night that the HSE has block booked City West until December the 31st?
We have booked City West. I think it's till the end of December. It was, I'm just trying to think, months. I think it was for about a 7-month period.
And do you foresee yourselves using that up until December?
I think part of our challenge with all of this is that we don't exactly know. You know, so clearly we hope that we won't be, and there are many things that we are developing that we hope we will never have to use. And that's what's tricky about this. There is no blueprint, or it's not like we're just developing a new service and we'll have it forevermore. This is an extraordinary response to something that has developed at pace, and we have to ensure that we have sufficient capacity available in the event that we need it. So that has been a priority for us.
We've had to put, if you look at the situation now compared to what we thought it might be a few weeks ago, we had about 600 or 700 new cases a day. And according to Philip Nolan, if you listened to his briefing last night, if that famous R value had stayed at 2.5, we'd have had 7,000 new cases per day. So it's only a few weeks since we had no modelling, bar the unmitigated modelling that we saw in Italy and early stage China. And as such, our planning had to allow, and still does allow, because if you listen to Professor Nolan's modelling, he talks somewhat encouragingly about flattening that curve. But what is less clear now is how we come back down off the top of the mountain, because the modelling the learning since then shows that any change in policy, the modelling is exquisitely sensitive with a sudden upslope again as we begin to open society again. So all those extra capacity, be it in City West, be it those ITU beds, be it the extra acute hospital bed capacity, the hubs remain part of our plans, because we have to plan for any uncertainties, which even though we've got through this stage in terms of the acute hospital pressures in a much better way than we might have worried about a few weeks ago, we still not quite sure what the exit phase will be and how that will impact on our acute hospital system.
I think it's important as well, Alva, to note City West is 2 parts, 2 distinct services, and part of it is already being used. Yes, self-isolation facilities, so I think it's important to note that. Okay, have you another question? Shane? Paul, did you have another question?
Oxygen. I'm just wondering about the availability of oxygen generally in nursing homes. I think it's probably an essential part of care for many of the residents. And in particular, going back to the Maryborough Centre in Portlaoise, did any of those patients get oxygen? And indeed in St Mary's Hospital in Phoenix Park, was it available there?
I can't answer a question specifically, Paul, because I'm not aware of the individual care details of each patient, as I discussed yesterday with you, and today I'm aware of what informed those decisions. As regards oxygen provision in nursing home, it can be part of care before COVID for patients with type 2 respiratory failure and chronic bronchitis or emphysema, and targeted oxygen may be part of palliative care in certain patients in the nursing home setting. So I'm aware part of our clinical support or the provision of oxygen. I can't go into details of individual patients on those locations. I just simply don't know what was provided in those settings.
Confirmation. Are you saying, and I think you said it last night, Colin, that your understanding at the moment is that there are no excess deaths showing up on the figures, although it's early days in your
be very careful, because what I said is that if you like, the traditional way of looking at excess deaths is somewhat historical, because it depends on registration of deaths. And you've seen some actions this week where the coroners have contacted funeral directors to expedite, accelerate that recording of deaths to make it more real time. So it may well be that there's excess deaths. It's just that the current reporting system hasn't yet captured that. But part of the work between NEFIT and ourselves this week is to expedite recording of deaths and to look at those trends in more real time to see if there's an excess of unexpected deaths in nursing home settings that may, for example, lead to a narrative that there are some people who are dying with COVID on board, either as a direct cause or as a contributing cause of death that we're not aware. So as this point in time, we haven't seen it, but that isn't to say it's not happening. When we have real-time data, we'll come back to you and let you know.
Okay. Have you another?
And do you have any idea why the Dublin City Coroner felt minded to remind clinicians of their need to register deaths, and why she felt that they weren't being reported in many cases?
I don't know, because I wasn't speaking to her about why she did that, but what I can say is she's probably, just like exactly what I said there, she's mindful, as we all are, that we need to, if there's an additional cohort of patients that may have died with COVID on board in nursing home settings, we need to find out in real time, and she's playing her part in prodding people to report as quickly as possible, so there's no lag time in that reporting.
Okay, Shane, back to you.
Yeah, sorry, I just wanted to ask about the story with private hospitals and when we're going to start using them to perform public services like surgery. This came up during the week at the Department of Health, and Dr. Tony Holland said there is a need to start. So I'm just wondering, when are we going to start in private hospitals doing public services?
I will just say that this is long-term residential. I'll give you a free pass on this one, okay? Because we're coming close to the end.
So we actually are, so there's work that's been underway with the private hospitals in respect of the contracts for the consultants, but in many areas work has started moving. So in different local arrangements between hospitals and their nearby private hospital, it hasn't been formalised in terms of the contractual piece with the consultants. That's underway now. But that work, and certainly our priority is to ensure that those facilities are used in the main for non-COVID urgent work.
Okay, happy enough, Shane? Okay, John, I think we're coming close to the end, unless anybody wants to put their paw up.
Sorry,
John is asking.
One more question in relation to the calculation of deaths, particularly within nursing home systems. And I just want this for accuracy purposes so that I understand it. So if someone dies in a nursing home situation and they may be suffering from some illness, they'd previously been tested for COVID or had been tested to establish whether they had it or not, and they pass away. So their test comes back maybe a week later or whatever it is. Is it at that point that that person becomes a COVID statistic, or is it, what way does it work?
Well, I can't speak for because in the great majority of cases these deaths are recorded and the certificate is signed by the general practitioner in nursing homes, and I would expect that most of them, if they were aware there was a suspicion of COVID, they would be well aware of it first of all, because the person who usually signs the death certificate is a medical practitioner who's familiar with the patient. So I would expect that in that context they would be aware of the need to wait for the registration to take into account the result of the test. I would have thought, I can't speak for everybody. John, isn't it? Yeah, I can't speak for everybody. I'm just thinking my own thinking when I fill in those certificates myself. If there was something significant on board, I would tend to wait for the test rather than write a certificate which demands a degree of clinical opinion and certainty. If a test came back after, in general, generic circumstances, if something came back after I'd signed the certificate, which I felt the coroner needed to know, which changed my opinion, I would contact the coroner directly. So to answer your question, one, I think I would imagine most people, if they thought a COVID test was awaited, and they'd know it because there'd be isolation and so on, they'd probably wait to sign it. And secondly, if something came back after they changed their first opinion, I'd expect they'd make a call to the coroner to notify him or her of what has happened.
Okay, Richard, round 3. This is like the PAC.
This is just in terms of clarification rather than anything else. Just from the Minister's Office, 18 COVID-19 response teams across 9 CHO areas, depending on level of difficulty being experienced. I could just explain, just in terms of, in real terms, what their actual job is. I mean, it includes stuff like on-site staffing, provision, facilitating preparedness. I mean, is that number of teams going to be boosted as well? What's the actual day-to-day job of what they're doing?
So again, it'll vary. So as with everything that we're describing around COVID, this is where we're starting. Well, we've started already in many areas. Actually, have people who are working as a team now. We're formalising that structure a bit more, because it's clear that we need to have very senior nursing personnel. So at a community health organisation level, we're going to have, more, I suppose, senior people assigned to this. But in terms of the teams that are there, they will be a combination of people. So clearly public health is critical. We will have nursing input, so senior nursing input, and we have already experienced quite a significant demand for senior nursing support. So just from nurses who may have, for example, advanced qualifications, etc., in either palliative care or in anything. We also will have other clinicians, so in terms of medical supports, and working with the local hospitals, have access to geriatrician support, general physician, microbiology, and critically infection control expertise. So it is our, what we want to have is all of that expertise, and we have, as I said, in many areas got that. We're going to enhance it more, and that team, I suppose, will be charged with looking to see what the specific requirement is in each nursing home, and it really does vary. So in some cases it is purely PPE, in others it is purely expert advice around one very specific thing, and in another home it may be much, much more than that. So what we want is to ensure that we have sufficient capacity available so that we can respond immediately when a home puts up their hand, and or alternatively when we are alerted with HICWA. What has been very, I suppose, important for us and very, very beneficial has been the very close working over the last couple of months with HICWA in relation to private nursing homes, because they have a much greater knowledge of what is going on in the private nursing home sector than we would have had traditionally. And we are working very closely with them, particularly in relation to their approach to infection control prevention within private nursing homes. So it's a kind of a, I suppose we will have teams that will have a whole range of expertise behind them, and they may or may not be used in different nursing homes depending on the set of circumstances. Sorry, just to say, we also have had a need for senior management support, not just clinical support, but in terms of managing situations such as this.
Okay.
One final one. Just in relation, the contact tracing app that you announced about 19 days ago, and you said that would come in 10 days. Where's that at?
Still being tested, and my understanding is towards the end of the month it's going to finish testing.
So it could be in for when restrictions ease?
That's the principal focus of it, not in this situation. So it is pretty much for that, when restrictions ease and when people start to move around a little more. But still being tested, still working through some of the privacy data issues, and also some of the platforms. One of the platforms in particular, trying to work through any challenges there. Okay, are we done? Okay, so I've had a number of questions come in by text, nothing at all to do with long care residential facilities, so I'll hold on those, asking those questions to the panel. We'll pick it up on Sunday. We plan to do our weekly briefing on Sunday, so those questions can arise there. Don't have a location for that yet, but we'll see you all on Sunday, and thank you all of you who've watched this from home. Thank you.